Yeah, there's working. Okay. So everybody grab a seat. All right. So does everybody know now how to turn on the machine? Maybe? Kind of? You know how to pick the right transducer? Maybe? No? Kind of? You know how to hold the transducer? Okay, most people said yes. All right, so let's talk about the FAST exam, okay? So the FAST exam it is a protocolized way to look at the abdomen. Now, it was originally described for looking at the trauma patient. That's why it's called the Focused Assessment and Trauma Exam. But really, it's just a way to look at the abdomen. So it gives you a method of looking at the abdomen, whether you're an emergency medicine guy, like a lot of us, or whether you're a surgeon and you're going to be doing trauma, or whether you're internal medicine and you're just looking for ascites or looking at the liver. It gives you a way of it, looking at the liver in a systematic approach. So we're really going to talk about it in the context of trauma, but it could be that you're doing it in the context of many other things. This is that clinical integration. So it's not just for trauma, it's for a lot of things, but we're going to keep it really in the realm of trauma for the lecture. All right, when I was talking to medicine and family medicine last week, we really talked about a lot of other things, but in this case, for most of you guys, we'll talk about trauma. So the role of the FAST exam is to diagnose free intra-abdominal fluid, also pericardial fluid and thoracic fluid, but really you're looking for free fluid in the abdomen, chest, or around the heart. All right, in the trauma patient, we assume that fluid is blood, but it may not always be blood. It could be a lot of things. So why do you want to use ultrasound when you have a lot of other modalities like surgery, CT scan, those kind of things? Well, in the trauma patient particularly, it's like the original indication for ultrasound. In the trauma patient, every second counts, really every minute counts. So the quicker you can make that diagnosis, the faster, better, smarter you are, as we talked about before, then the better you can take care of your patients. You make diagnoses quicker, you can get them to OR quicker, you can get them definitive treatment quicker. So that's really important. And you also find that your physical exam really stinks. So you will see young, healthy people that, like any of you, if you had a trauma wreck out there in the parking lot right now, got hit by a car and tore your spleen off and you're bleeding all into your belly, you've lost 2 liters of blood, half your blood's in your belly, and I laid you flat, your vital signs would probably be one. And that is a problem, because if you're just relying on vital signs to tell you who's sick and who's not sick, you're going to miss a lot of people. And that happens all the time. Well, the FAST exam, it helps you detect that free intra-abdominal fluid. You can tell with your eyes if there's bleeding all over the street, but you can't see inside the body. So ultrasound helps you. Now, you do have another modality that gives you a lot more information, CT scan, right? What's the other name for CT scan? The truth machine, right? You put somebody in the truth machine, it tells you what's right, what's wrong with them, right? But the problem is the truth machine is not on the same floor in our hospital. It's a long ways away from the ED. And if you've got a sick patient, you really don't want them to be away from you or your monitors or being able to treat them. So you don't really want to send sick patients out of the ED without being prepared. So ultrasound helps you because it's done bedside. You don't have to send the patient out of the trauma bed. You don't have to get them away from all of your equipment. So they are where you are, and that is good. It's as sensitive as a DPL, diagnostic peritoneal lavage, which nobody in this room will ever truly do, which is a way of diagnosing free fluid in a trauma patient, which is an invasive method. Now, you may do a paracentesis, but that's not really a DPL. There's probably nobody in this room that will ever do it, even if you did do it last week in ATLS or whatever. You will never do it, because ultrasound is non-invasive and is equally as accurate, and is more accurate, and it is certainly a lot more rapid. And ultrasound can be done while you're doing everything else in the trauma bay. So while you're getting vital signs, while you're doing the primary, well, usually it should be after the secondary survey, but while you're doing your secondary survey, while you're getting some point-of-care labs or x-rays, you can be doing ultrasound. And you can also repeat it. So if the patient gets unstable or starts acting funny after you do your initial exam, you can repeat it and see what happens. Now, the clinical indications for doing a FAST exam in trauma patients are these. Anybody presenting with trauma and anybody with altered mental status that could possibly have trauma. Now, if you're expanding those indications to anybody, you can do a FAST exam on anybody. So my example is, if you go scan for appendicitis in a 5 or 6 year old with Dr. Kuhn in the ED, he's going to do a FAST exam first, because the FAST exam orients you to the abdomen. If you see free fluid in the abdomen on a 5-year-old, there should be no free fluid. That helps you know maybe it's a ruptured appendicitis, and that's free fluid is not blood, it is pus, right? So that gives you some information that you can use to help your patient. So almost any abdominal exam can have a fast exam as part of it. So it's a really good exam to start off with. That's why we start off with it. But in trauma patients, the reason why a fast exam is great is because if you've got a hypotensive patient that got hit by a car, and you look in there and do their fast exam, they got a belly full of blood, you don't need to go to the truth machine. You know what's wrong with them, something. You don't know exactly, but you need to go to the OR and get it fixed. So it obviates the need for any further diagnostic testing. You can move on with life. Now, today we're going to do 3 different exams. We're doing the fast exam, where we're going to use the abdominal or curvilinear probe to look in the abdomen. We're going to do the cardiac exam, where we're going to use the phased array or cardiac probe to look at the heart. And then we're going to do the linear or the flat face probe, which is for procedures, which some of y'all have already done, which is for doing vascular access and those kind of things. So again, all of our probes have all 3 probes. So if we were just looking at the abdomen, we're going to use this abdominal or curvilinear probe. It gives us a wide field of view, which means we don't have to move the probe as much to see it well. That's what we were just using when we were doing our practice to the machine. That works really well. If we were looking only at the heart, we'd use the phased array, but the phased array can look in the abdomen. So sometimes I'm looking at the abdomen with the phased array probe. It is a little bit more complicated to use the phased array to look in the abdomen, but it is certainly capable of looking in the abdomen. This one is very capable of looking at the heart, but it doesn't give you near as good a pictures as this. So these are kind of interchangeable probes, but this one is primarily for the abdomen. This one is primarily for the heart. Now, the images for the fast exam are the right upper quadrant, heart, left upper quadrant, and pelvis. It's around the circle. We are not going to talk about the heart in this lecture. We're going to have a whole dedicated lecture next, assuming I can get it done in time, which we will. And so we're going to not talk about the heart right now. We're just going to stick to the abdomen. So the first view you look for is the right upper quadrant view, or the Morrison's pouch view. And you're looking for the largest organ in the abdomen, which is the liver. Superior to the liver is, what is this structure? Diaphragm. What's inferior to the liver? Kidney. What's between the liver and the kidney? Morrison's pouch. This organ is intraperitoneal. This organ is retroperitoneal. So this is the dividing line between intraperitoneal and retroperitoneal. So this is why fluid collects here and not below the kidney. The kidney is retroperitoneal, so intraperitoneal fluid cannot get behind the kidney. It collects above the kidney, between the kidney and the liver. Does that make sense? All right. What's above the diaphragm? Lung. But it's also the thorax. So fluid collects here at the diaphragmatic spine junction, right? This is the costovertebral angle right here. So fluid collects here. So a hemothorax or a pleural effusion will show up here. Right? So you just diagnosed how to look for fluid in 2 body cavities with 1 view. All right. Subxiphoid, we're going to come back to in the next lecture, but we look up under the ribs at the heart. We can also look at the IVC. Again, that's what we're going to do in the next lecture. And then we go over to the left upper quadrant. The left upper quadrant is a harder view to get than the right upper quadrant, because this organ, which is spleen, is much smaller than the liver, so it has a smaller window. So in your last group, they should have talked about windows. Your window is how you see into the body. It's a tissue interface that allows the ultrasound beam to transmit into the body. There are things in the body which don't transmit sound well, which are the enemies of ultrasound, which are air and bone, and then the other enemy is distance, right? So this has a smaller window, so you have, if you want to be a rock star, everybody is performance oriented, you want to be a rock star, you want to show up the trauma surgeons that I taught this trick to already, right? You want to take your probe and place it up and down the body and put your hand on the bed. When you put your hand on the bed, you angle your transducer up into the body, you will always get this picture. If you don't get this picture, you're too far down the abdomen. The spleen lies up in the chest, underneath the ribs. So slide up a couple ribs and you always get it. We'll repeat that in a minute. And then the last view is the pelvic view. You want to look for the bladder. You want to look side to side around the walls, and then you want to turn 90 degrees. This is the only view in the fast exam where we do it in 2 views. So we do a cross section and a long axis. And we look for free fluid outside the bladder. Right? This is urine in the bladder. All fluid is black. Urine is black. Blood would also be black and would be outside the bladder. All right? So you want to get this exam done before they get a Foley, because once they get a Foley and the bladder is decompressed, you lose your window and it's very hard to detect a small amount of fluid. So the fast exam should be fairly fast. So here's the liver. We are panning through that space, which is Morrison's pouch, from one side to the other. We look up above to look at the diaphragm. We look below to look at the kidney, lower pole of the kidney, which is the pericardial gutter. We're going to look at the heart, which we're going to come back to, but we usually go around the clock. So we're going from liver to heart to left upper quadrant spleen. Put your hand on the bed, angle up a little bit, and you should get the spleen and the kidney. If not, slide up the ribs a few spaces. And then we go down the bladder. He does the long axis first. We look side to side, up and down. And then we turn cross section and look side to side. And we're looking for free fluid outside the bladder. All right? This should only take a minute at most. Now, when you're an intern or you're a student, and you've not done this before and you're very confused about what's going on, especially in a chaotic trauma bay, and you've got surgeons yelling at you, hurry up, what are you doing? Why is a medical student touching the probe? What are you doing? Where's the heart rate? Where's the vital signs? We got to go to CT. Yeah, it can be kind of intimidating. This should take about a minute, maybe even a half a minute, all right? This should be fairly fast because you know what you're looking for. You're very focused. You're oriented to looking for free fluid. And if you don't see free fluid, you're moving on to the next view. The temptation, though, is to just look at Morrison's pouch. There's the liver, there's the kidney, there's Morrison's pouch, and move on. No, you have to pan all the way through it. We'll see that again in a few minutes. What are we looking for? I told you you're focused oriented. We are looking for free fluid. All fluid is black in ultrasound. Fluid is always black. It doesn't matter whether it's blood, urine, pus, ascites, it's all black. Now, we make the assumption in a trauma patient that if they got free fluid in their abdomen, they don't have any reason for that, right? They got hit by a car, that's their reason. But they don't have peritoneal dialysis, right? They got fluid in their belly, it's blood. That's what we're deciding, right? And it's blood because that's the way we clinically integrated what we're seeing. That takes your brain, right? It could be an assumption, it could be wrong. But fluid is black. And we're looking for fluid where there should be no fluid. There should be no fluid between the liver and the kidney. Remember, this is retroperitoneal kidney. This is intraperitoneal liver. So fluid in the intra-abdominal space will collect between the two of those. That's the deepest recess in the supine patient. So fluid will collect there, and it looks like a black stripe. Here's the spleen and the kidney, and here we see a black stripe that's outlining the spleen and the kidney. Right? So that is black fluid. That should not be there. That is not within an organ. It's not within a vessel. It's not within the bladder. That is free fluid. That means that is abnormal. So how good is the FAST exam for picking up free fluid? This is an older study back from 2001. Used almost 3,000 patients. How good? 84% sensitive in picking up free fluid. All right? That's pretty good for a medical test, to be honest with you. It's actually probably a little bit better than that. But the FAST does miss injuries, all right? The injuries that are missed in the FAST are things that don't have bleeding into the intraperitoneal space. That's all we're looking for. We're looking for bleeding in intraperitoneal space. If you have an injury that does not do that, then you will not pick it up with the FAST exam. So retroperitoneal injuries bleed retroperitoneally. We don't look at the retroperitoneal. We're looking at the intraperitoneal. We're looking at fluid for the intraperitoneal space. Bowel injuries rarely bleed, right? It may spill gastric contents or it may spill, duodenal contents into the abdomen, but usually it's a fairly small volume. So we cannot pick up bowel injuries. And we cannot pick up solid organ injuries like liver hematomas that are not bleeding into the abdomen, right? If they're contained within the capsule, we can't see them. We're looking for free intra-abdominal fluid. All right, so what are the injuries we miss? We miss retroperitoneal injuries, bowel injuries, and solid organ injuries like liver that are not bleeding past the capsule. Okay, got that? That's a lot of injuries you're going to miss. All right? It also has to be a certain amount of blood before you can see it. So if somebody gets to the hospital really fast, let's say they get hit on 15th Street and EMS is right there and they bring them right in the trauma room and they've ripped their whole liver off of a huge liver laceration and it's bleeding a lot. They may have gotten there so quick that there's not enough blood for us to pick up. So it takes some blood in the abdomen before you pick it up. How much blood does it take? Well, it turns out it takes a fair amount of blood before you can see it. People like Dan over there, me, Jed back there, been doing this for a while. We can probably pick up maybe 400 cc's of blood. Okay, is 400 cc's of blood a lot of blood? Yeah, that's a fair amount of blood, right? A couple of units of blood in the abdomen. But that's not very much on a FAST exam, so it's hard to see. All of you guys can probably see a whole liter of blood. Is that a lot of blood? Yeah, a fifth of your blood volume in your belly? Yeah, that's a lot of blood, right? So about what you're going to detect in the trauma room under stress is somewhere around a half a liter of blood. So if you see a very small stripe of fluid, it's a lot of blood. Does that make sense? So a small stripe does not mean a little blood. A small stripe means a lot of blood. So let's go back over the negatives of the FAST exam. You can't detect retroperitoneal injuries. You can't detect bowel injuries. You can't detect solid organ injuries that are not bleeding. You guys might not be sensitive enough to pick up large amounts of blood in the abdomen. And if you do an exam, it may give you a false insecurity that the patient's okay and they're really not okay because you didn't see the blood that was actually there. Those are all bad things, right? So why do you want to do it? The reason you want to do it is because of this study. This was a randomized controlled trial back in 2006, a long time ago. That's like, some of you guys were in high school back then, right? Middle school. Elementary? Elementary school? I don't know. It was a long time ago, right? That's a long time ago, right? It's not that long ago. So look, this was randomized. So some of these centers had ultrasound as part of their their trauma algorithm, and some of them did not. Those that had an ultrasound on every patient that came in got to the OR, look at that, 60 minutes faster, right? An hour faster. Why is that? If you guys had this x-ray vision and you said, this sick patient comes in and you go, there's something wrong with them versus there's not anything wrong with them, you will act different, right? So if the trauma patient comes in and you put the trobe on, everything's normal on their vital signs. They're complaining of some abdominal pain. You put the transducer on there, their belly's full of blood. Do you think you're going to go faster or slower in getting that truth scan, right? The CT scanner. You will go faster, right? If you go faster getting your diagnosis, you go faster to treatment, all right? So the FAST exam makes a big difference in trauma patients. That's why I tell you to do it on every patient. Do it on every patient because you'll be surprised. You're going to put the transducer on there at some point and you're going to say, I'm doing another negative FAST. This one's positive, and you're going to go faster. And you're going to change the mind of some surgeon that was going, yeah, I want to go see this other trauma patient. No, they're going to pay attention to that patient because they know they have an injury. All right, so it helps you know who to treat quick and who maybe can delay and be a little bit slower, right? So again, if you have free fluid in the abdomen and their blood pressure is low, you don't really need the truth machine. You're just going to go straight to laparoscopy. And most of the surgeons are pretty good about that. Now, there's still some that want to get a CT scan because it makes them feel better knowing what they're going to go in there and have to deal with. But if they're really unstable, they really just need to go to the OR because the CT scanner is not fixing anything. The only thing it's going to fix something is cross-clamping whatever's bleeding. Right? Every other patient, unless they really don't have a lot of injuries, is going to get a CT scan because the CT scanner is the what? Truth machine, right? You've got to find out what's wrong with them, right? So even if you have free fluid on your ultrasound, you probably don't, if they're stable, you're going to get a CT scan. Because you want to know what's wrong with them. And some liver lacerations, we don't do anything about. We just watch them, especially in kids. All right? If they don't have free fluid and they've got abdominal tenderness, what are you going to get? A CT scan, because you want to know why their belly hurts, right? They just had trauma. So this does not obviate the need for CT scan. It complements it, right? It complements your physical exam. It complements everything you're doing. It makes you better, faster, smarter, right? And that's one of the reasons why we're doing things. All right, so let's look at some examples. This is the right quadrant, so this is the liver. This is the kidney. Everybody see the black stripe of fluid? Is it dark enough in here to see? All right. If you look on the side, each one of these ticks, right, is 1 centimeter between them. So if you look at this stripe of fluid and you map it out over here, it's about a 1/2 centimeter stripe of fluid. So that's about a 1/2 liter of blood. Okay? About a 1/2 liter of blood on that patient. All right? Is that a lot of blood? Yes. And from here to here is a centimeter, so if you had a stripe that was a centimeter, that would be about a liter of blood. Is that a lot of blood? Absolutely. Yes. Here's another exam. Is it positive or negative? The answer is always on the screen, or you can follow the lecture. These are all positive. So what do you think? Is it positive? Yes. Where's the fluid? Is it right there? That's the fluid, right? No? Is that not the fluid? All right, that's the vein, right. Remember that the IVC runs posterior to the liver and the hepatic vein runs right into it, so those are not what we're looking at. But Morrison's pouch looks pretty clean. There's no blood in there. Does anybody see any blood in there? No, but you do see some up here. Watch when it plays. See, when that rib gets out of the way, there's a stripe of fluid up there. Remember, you have to look at the whole thing. That's why Jed or Dan or Ted or I can pick up smaller amounts of fluid because we're looking at the whole picture. We're not focused in on right there. That's the only thing I'm looking at. And that's what you'll see is when you get under stress, you're going to start cutting things out of your exam. And you're going to start focusing in on what you know, right? And then what you know is I'm going to look between the liver and the kidney, and that's negative. But I didn't take into the whole account that I'm looking at any of this space, any place that there's fluid there shouldn't be, and there's fluid right there that should not be there. So that's a positive fast exam. That's about a 1/2 centimeter stripe of fluid, so that's about, half a liter. All right? You can also go above the diaphragm. So here's the diaphragm, the liver, the kidneys down here somewhere. Here's the spine. What is this black stuff? Black is always fluid. In the trauma patient, it's blood. But if they're the non-trauma patient, is pneumonia, what is it? Effusion, or it could be pneumonic effusion. It could be a hemothorax. What is it? Help me out. Chylothorax, any of that stuff. What's this stuff in the fluid? What's this?
Lungs.
Lungs. Why can you see lungs? We can't see lungs because they're full of air. We can't see air. Because they're collapsed, because the fluid has pushed all the air out, so this is the lung tissue without air. So this is compressive atelectasis. Everybody got that? All right, don't forget to look at the inferior pole of the kidney. The inferior pole of the kidney is another potential space. This is why we can pick up smaller amounts of fluids than you do. It's negative here, but it's positive here. Why is it positive there? If I come in walking and I've got blood or fluid in my abdomen, what view am I going to see the fluid? Here I am, I've got a liter of blood in my belly. What view am I going to see the fluid? The bladder, because the fluid is down in my pelvis, right? If I lay down, and I've been laying down on my ambulance ride in from South Georgia, right, where's the fluid going to be? Right upper quadrant, because that's the deepest part of the belly, okay? If I came walking in and I lay down, and the fluid has to migrate from my pelvis to my chest, or to my upper abdomen, maybe it's in this part, right? So it's in transition, all right? So you got to remember, you got to look at the whole place. Any fluid outside of a vessel, outside of where it should be, is positive. This is pericolic gutter. It's very rarely positive in isolation, but it can be. Here's the left upper quadrant, spleen. Kidneys down here is off the screen because fluid almost never collects between the spleen and the kidney. It almost always collects between the spleen and the diaphragm. Okay? The reason is there's a ligament that attaches the spleen to the kidney and it just doesn't collect there. Right? It's very rare. All right? It most often collects between the spleen and the diaphragm. So you have to see the diaphragm, particularly on the left side, to say it's negative. However, where does splenic blood, let's say you ripped your spleen, it's bleeding profusely, where does it collect in the supine patient? Right upper quadrant. Where does it collect in the ambulatory patient? Pelvis. All right? So why would fluid collect in the left upper quadrant? If they're laying on their left side, right? Why would they be laying on their left side? Close. Usually on the spine board, they start vomiting because they, splenic injuries, they vomit a lot. So they're vomiting. What does EMS do? They roll them on their left side, left lateral decubitus, right? So that's the downward part. That's where you most often see a positive, okay? Here's another one. Here's the spleen. The kidneys down here a little bit out of view. Look at all that fluid between the diaphragm and the spleen. Is that a lot of blood? That's a whole lot of blood, all right? That's a patient that was riding their bike and the handlebar hit them right in the spleen. Wham! All right, they're bleeding out in their belly. You better do something. All right, the pelvis is a little different. All right, we like the pelvis because we got this nice window, so we have this black fluid. So anytime you see the wall of the bladder outlined, as we do here, you can see the wall, that's abnormal. This is actually an ovarian cyst. Over here, it's contained. This fluid is contained. That's why it's nice and round. And it's bleeding. So this is fluid in the pelvis or blood in the pelvis, and it's from this ovarian cyst. That's free fluid in the pelvis. All right? Here's a different one. This is a trauma patient. You can see the wall of the bladder outline. Boom! You knew immediately that was abnormal. Fluid in the bladder, fluid out of the bladder. Fluid out of the bladder. That's immediately positive. Okay? See how you can recognize that now? It doesn't take you long to know normal from abnormal. Because when you see a wall of a bladder outline, it's always abnormal. Now you got to remember, not all fluid is blood, right? We already been over this a couple of times. If the steering wheel hit you in the bladder and you had a full bladder and it ruptured your bladder, it could be urine in the belly. It could be ascites, right? It could be pus. There's a lot of things because fluid is just fluid. The only way for you to tell the identity of fluid is to stick a needle in it, all right? We don't do DPLs, but we do paracentesis. There was a case we didn't have too long ago where Dr. Holston and I, he's a trauma surgeon, in case you don't know, we were sitting there looking at this very sick patient, and he and I were debating, is it their gallbladder and they're septic from their gallbladder, and that's why their blood pressure is low and they have free fluid in their abdomen because it's pus? Or is it because they fell and they've injured themselves and it's not their gallbladder and that's blood in the belly? Stick a needle in. Pus came out, that was their gallbladder. So we took them to the OR for their cholecystitis. We had drawn out blood and you take them to the OR and said, okay, it's that liver fracture from that fall. All right, so you can figure it out, but most of the time you use your brain. So just some pearls, okay, and we're almost done. All right, so remember, if you're going to do one fast exam, if you're not going to do a CT, you should probably do another one because remember, it takes time for blood to collect. All right, so try and do 2 fast exams if you're not going to do a fast exam and a CT scan. What's the diagnosis? Is it positive or negative? I got a bunch of positives up here. Anybody over here? I got a couple of yeses. All right. Where's the fluid? Is it right here? Inferior pole of the kidney. So it's down here in the pericardial gutter. All right. So when you tilt and you look, it's down here. Remember, fluid takes time to transit up from the abdomen once you lay them flat. The time where you see this positive, where it's the inferior pole, is almost universally the same kind of patient. It's the ambulatory patient that is going, oh, my belly hurts. And then you lay them down, because they come walking in triage, you lay them down and you scan them, and the fluid is moving from their pelvis up here, and it's almost always an ectopic pregnancy. So, because young, healthy ladies, like I told you, can tolerate, loss of blood, and they don't lose their vital signs, so they come in with abdominal pain, and the nurse takes their blood pressure, and it's 80/40, and they go, oh, this is bad. And so they rush them back to a C room, and they lay them down, and you catch it at the inferior pole because it's migrating up, and it turns out that they've got a ruptured ectopic pregnancy. That's what that one was. Here's the the liver. Here's the kidney. Is it positive or negative? Positive. All right. So look at the date on this. This is the very first portable ultrasound machine ever made. This is the Sonosite 180 Plus, which we still have. We actually gave it to the vet the other day, so we can use it in helping us out with some other stuff. But the reason why I showed this is because the screen is so small that the dots are really close together. So this is still about a 1/2 centimeter stripe of fluid. And since it's a 1/2 centimeter stripe of fluid, how much blood is that? About a 1/2 liter, so a lot of blood. All right, does that make sense? Don't be confused about size. Little stripes, a lot of blood. All right, what about that? What is that? There's the kidney. There's the liver. It's floating in fluid. That would be good or bad? Bad, but you need to know the clinical context, right? So if that was the trauma patient, would that be bad? That'd be horrendous. If that was the young, healthy female that has an ectopic pregnancy, bad. If that was a psyche, maybe not so much. So you can't tell the diagnosis about the image I gave you. You have to put it into the clinical context. So I tell you, hey, this patient is pregnant. This is a young, healthy female. She's pregnant. You do an ultrasound, a transvaginal ultrasound, which we'll be doing later in the year, about March, February, March, sometime in there. We're going to learn transvaginal ultrasound. This is all free fluid in the pelvis. It's actually blood. You can tell it's blood, and clotted blood at that. And then there's an ectopic pregnancy on here somewhere, but you've got free fluid, free blood, it's over there, free blood in a healthy young female, and it's up in the right upper quadrant, and her pregnancy test is positive. She has ruptured ectopic pregnancy. But if she was not pregnant, it could have been a ruptured cyst that causes that much blood. That happens sometimes. It could be ascites from their cirrhosis. It could be pus from their ruptured appy. Right? Does this make sense? You have to put it together with your clinical knowledge to know what it is. So that was a quick overview of the FAST exam when it comes to the abdomen only. We're going to come back and we're going to do heart. So I want everybody to go next door. I know they're rotating you in and out. You've got to be back by a little bit after 3. And then we're going to do cardiac, okay? Does anybody got any questions on the FAST exam? Good. Let's keep going.